Hi, everyone. It's so exciting to be with you all today and to see all the names and organizations and locations in the chat. Warm welcome to this discussion about engaging leadership in a comprehensive equity strategy. We are so excited to be beginning this series of webinars designed to support healthcare organizations in addressing equity issues. I'm Tara Oakman from the Robert Wood Johnson Foundation and super excited to be moderating this important conversation about how to move healthcare forward in efforts to, quote, raise the bar for equity and well-being. For years, the foundation has been working to do just this, and we're still learning. The vision guiding the foundation's work in this area is for healthcare and public health systems to be fair and just, to treat all people with dignity and respect, to rectify past harms and prevent future ones. And to help in this regard, the Raising the Bar project provides an actionable framework for healthcare organizations to advance and coordinate equity efforts. At the Robert Wood Johnson Foundation, we hear often from healthcare leaders who want to advance equity and be a part of changing the system. And we also hear that they know healthcare's roles must change, but don't know where to start, or that their existing efforts can feel disjointed. So in thinking about this work, it was clear to us and to many of our grantees that healthcare leaders both want and need a guide. And that's part of why the foundation launched Raising the Bar. Raising the Bar has been steered by a coalition of partners led by the National Alliance to Impact the Social Determinants of Health, or NASDO. This coalition drove the ideation, evidence gathering, stakeholder input, integration, and translation processes that resulted in the framework. I think it's important to mention also that Raising the Bar was developed by those who give, get, and pay for healthcare, and was shaped by those who experience inequities. By talking to a variety of stakeholders, Raising the Bar uncovered critical insights that informed the strategic framework all of us can use to help to move healthcare forward. These critical insights include: 1, patients want systems that treat them with dignity and respect, are accessible, and offer whole person care. 2, hospitals and practitioners want systems that incentivize care that is integrated, patient-centered, and focused on prevention. 3, payers and systems want financing to help to address social determinants of health at the community level. And last, but certainly not least, community organizations want trusting, co-equal partnerships with health and healthcare systems. The result is that Raising the Bar takes a 360-degree perspective to health equity. It's not just what a healthcare organization does in the community. It's not just how it treats patients. It's not just about the workforce. It's about approaching its work and its roles differently. Raising the Bar offers healthcare leaders practical ways to operationalize efforts to pursue equity and well-being. The framework, which you can see as a link in the chat box, offers 5 cross-cutting principles that ground this work, 4 roles that healthcare must play, and 14 actions that offer specific approaches to advance equity in your organizations. Early next year, the National Partnership for Women and Families will release guidance on how to apply the Raising the Bar framework to maternal health, to demonstrate how healthcare can improve care delivery in ways that respond to people's individual needs, address bias and discrimination, and improve the quality of services. This important work relies on CEO and board level commitment and true partnership with communities to be successful. Our work has shown us that organizations that have had success in advancing equity initiatives had the support, resources, and engagement from their CEO and board. Without C-suite engagement, equity efforts can get siloed or tacked on to existing programs. They become part of a checklist rather than a true organization-wide commitment to change. So I'm excited to dig into these issues today. Today, we're going to speak with 3 healthcare leaders that are on the ground doing the work to support equity efforts in their organizations. And we'll hear from them about what they're doing and specifically how they ensured and continue to maintain CEO and board level buy-in. Following our initial discussion, we'll open up the conversation to questions. And throughout today's discussion, please use the chat feature to submit your questions, just like you're already doing with where you're coming from. So glad to see it. So I'm pleased to introduce our esteemed panelists. We have Mikelle Moore, who is Chief Community Health Officer at Intermountain Healthcare. Mikelle has been part of Intermountain's leadership team for more than 20 years. Based in Utah, Intermountain is a not-for-profit system of 33 hospitals, a medical group with more than 3,800 physicians and advanced practice clinicians at about 385 clinics. Mikelle is a pioneer leading healthcare's pivot towards addressing the social determinants of health. And in addition to her Chief Community Health Officer role, Mikelle serves as the president of the Intermountain Community Care Foundation. We also have Dr. Dawn Godbolt, who is Director of Health Equity at the Maven Clinic. Dawn provides critical support across fertility, pregnancy, adoption, parenting, and pediatrics for families. Since its launch, Maven Clinic has helped millions of women and families navigate their health by putting them at the center of their care. Dawn's early career was in emergency housing, and she holds a PhD in sociology with a concentration on race, class, and gender inequalities. Previously, Dr. Godbolt served on an expert advisory group working to translate the Raising the Bar principles to specifically improve maternal health. These, again, will be released in early 2023. And we also have with us Dr. Gary Stuck, who is Chief Medical Officer for Advocate Aurora Health. Dr. Stuck, a family medicine physician for 32 years, Gary leads safety, outcomes, and population health management for Advocate Aurora Health. Advocate Aurora Health is one of the largest not-for-profit integrated health systems in the United States and the leading employer in the Midwest with 75,000 team members. The health system serves nearly 3 million patients annually in Illinois and Wisconsin across more than 500 sites of care. Gary is a co-executive leader of the Advocate Aurora Health Equity Council, which has successfully engaged advocates' C-suite and board in supporting organization-wide health equity efforts. Thank you all for joining us today. So Mikelle, I'm going to start with you. In 2020, as a result of George Floyd's murder and other calls to end racial discrimination, as well as inequities further exposed by the pandemic, we saw organizations across the country offer a public commitment to addressing inequities and bias in their companies. At that time, Intermountain established equity as a fundamental and a value. Can you tell us more about that, how that came about and how it is being operationalized?
Of course, Tara, thank you. And thank you for having me. Just as many organizations did, we felt it was really important to tell our caregivers, that's how we refer to our employees, what we stand for. And we started with our CEO, Dr. Mark Harrison, making a statement, video statement to all of our caregivers and our community around our commitment to equity. But we didn't feel like that was enough, nor did it have staying power. There were lots of people making statements, and we are a continuous improvement oriented organization. We really wanted to make sure that we embedded a commitment to equity into the way we do our work, the way we connect with other human beings in our caregiving approach, but also that we make demonstrable strides towards improving the equity of our organization. So in our culture at Intermountain, that means creating equity as both a value and a fundamental. And what I mean by that is there are our core values that we live by. And every value gets talked about in terms of guiding our leadership capabilities, our expectations of governance, our expectations of any caregiver's behavior. So we added equity as a fundamental to our existing values of mutual respect, accountability, trust, and excellence, and integrity. We now had equity in the way we work, which then influences all of our education and training and accountabilities. But then we added it as a fundamental as well. Intermountain is a very goal-driven organization, as we probably all are in healthcare. So whenever we set a goal, we're pretty likely to achieve it because we orient all of our priorities around those goals. Those goals are adopted at the board level, and executives are accountable to those. And every caregiver has the opportunity to influence our goal setting process. And we set goals in each of 6 fundamental areas. We added equity as a fundamental, which means there were board level accountabilities in equity around our hiring and promotion of caregivers, our clinical care delivery, equity for members, and equity initiatives within the community in terms of resolving disparities at a population level. Those goals get cascaded to every caregiver in a way that they can contribute to those goals, and we're measured on our performance. And we're using those metrics to create an equity metric, an equity index that we hope measures our progress towards creating an more equitable organization over time. So that's what it means, taking that statement and putting it into our behavior and our action as an organization. And I'll share just one example of what that looks like clinically, because that's really the most important aspect of our work. We identified a disparity in the way that we were delivering care despite our best intentions. Take our stroke outcomes as an example. We measure in our CMS measures and other quality standards the door to treatment time for caring for stroke, among other conditions. Our times didn't vary by race, ethnicity, language spoken, or income level, thankfully. And yet, there was a gut feeling by our caregivers that the health status of the individuals after stroke were different. And so we looked into the data a little further, and their gut instincts were right, that the health status, the morbidity following a stroke did vary. And the factor by which it varied most, where there was the most variation, was in language spoken. If someone spoke a language other than English, their mental status following a stroke was poorer than those who spoke English as their preferred language. And as we uncovered that further by engaging community members in speaking to us about these issues, we learned that it was really a disparity around education, recognizing the signs and symptoms of stroke, differences in comfort in seeking out medical care early in the onset of stroke symptoms. And we're now working on addressing those issues. So diving deeper into our understanding of health equity is what's really come about as a result of this focus on equity in our organization. Thanks, Tara.
Yeah, thank you so much. That's really good to hear about, and also how you've used accountability and measures and data to really look at continuous improvement and holding yourselves accountable. Appreciate you telling us more. Dawn, I'm turning to you next. So in your new role at Maven as a director of health equity, we want to recognize that you are new in this role. And so in our research, we've seen many organizations initiate and elevate staff positions that are focused on equity improvement. Can you tell us what an equity officer or director of health equity does, and how you specifically are working with your CEO and board to ensure that equity is integrated in meaningful ways, as opposed to a checkbox?
Sure. Good afternoon. Thank you for having me. And I think that Mikelle and I are probably touching on some similar themes. So I'll talk to you a little bit about my role, but first I'd like to tell you a little bit more about Maven and who we are. We are the largest virtual clinic for women and family health. We cover over 16 million lives, serving diverse employee populations of companies of all sizes across all industries with our innovative digital family health platform and our unique care model. We're able to offer 24/7 access to personalized care when and where our members need it. If a new member is struggling with breastfeeding or sleeping at 3 a.m., they can book an appointment with a Maven specialist in less than 1 hour and get immediate support. We connect our members around the world with providers committed to inclusive, culturally relevant care. And our clinician-designed care management programs offer personalized action plans to improve health, educational content, and live classes. And so our health equity approach really requires us to understand the context of our members' lives and to meet our members where they are across a number of intersecting domains, including race, gender gender identity, sexual orientation, geographies, industry, income levels, and of course, clinical risk. Our CEO and board members engage in health equity because we put our fees at risk for improving health outcomes across diverse populations, and it is impossible to do that in the maternal health space without a health equity strategy. Our CEO and founder, Kate Ryder, started Maven in 2014 as a way to navigate her own pregnancies. And Maven since then has morphed over the years as member needs and profiles have changed. To better meet the clinical needs of our members, Kate hired a chief medical officer, Dr. Neil Shaw, to run the clinical side of the company to drive forward efforts to improve health outcomes for all people, but especially those who are the most vulnerable to intersecting oppressions that manifest as health inequities. Dr. Shaw installed a scientific advisory board that is disproportionately made up of women of color and Black women, to be more specific, to provide both guidance and oversight. By installing the scientific advisory board, we are able to design health equity with an emphasis on data into our strategic planning. Dr. Shaw also hired me as the Director of Health Equity. I am housed within the Office of the Chief Medical Officer. I report directly to the Chief Medical Officer, and my influence spans both our clinical org and the business side of the house. It's really about building accountability mechanisms throughout the entire company for health equity. Are our frontline providers trained in culturally relevant care? Do we have quality improvement measures tied to health equity? Are we driving partnerships with community-based organizations and other groups on the ground? Do we develop health equity scorecards for all of our content, our birth plans, and any interactions that we have with our members? It's making sure that our engineers who write our code understand how AI can reinforce inequity. And so to keep our board engaged, our fees safe, and to improve our members' health, we have a two-pronged approach to health equity. The first starts at home. It's our own internal practice, or rather our DEI efforts. It's our rigorous hiring practice. It's any number of employee-run affinity groups to champion staff from diverse backgrounds with safe spaces. We vet all of our suppliers to make sure they have their own DEI goals and initiatives. And then lastly, we partner with community-based organizations. Again, those are groups who are on the ground in underserved communities to demonstrate that we think of health equity as a bi-directional process. Our second domain of health equity at Maven is how we support our members. We have targeted clinical programs that address specific member needs, like access to increased mental health services. Some new data that we recently shared with ACOG shows that our Black members utilize appointments at higher rates than white members, suggesting that digital care can fill gaps. We train all of our providers in implicit bias and trauma-informed care delivery. We are again deliberate in the diversification of our provider network, with roughly 40% of our providers identifying as Black or Brown. And then, because we know the data on concordant care or care matching, we are able to match our members with providers who share similar backgrounds and experiences. So our health equity strategy is bi-directional. Neil and I report to Kate and the board gives us our charge. They set our annual objectives, our key results, and again, because fees are at risk as a maternal health provider network and platform, we have to be able to play in the health equity space. We have to play well in order to have a meaningful impact on the health and well-being of our members. And our CEO and board understand that DEI and health equity are iterative processes that require intention, investment, and commitment from the top down.
Wow, thank you so much. Definitely not a checkbox, as I said in my question. I really appreciate hearing about all of that. So now I'm going to bring in Gary, and I look forward to the discussion among all of us. So Gary, in 2020, Advocate Aurora signed onto a statement declaring racism as a public health crisis, along with 27 other healthcare organizations. This included a commitment to improve hiring and retention processes for people of color and other diverse backgrounds, and to combat health disparities in the communities you serve. How have the CEO and board become engaged in all of your equity efforts?
Thanks, Tara, and thanks for having me here. I think you're going to hear a few common themes with my fellow panelists, but I think aligning with the work around raising the bar is so important. And for us, it's really about putting those pledges into action and really making a difference. Our purpose at Advocate Aurora is to help people live well. And that means everyone. We want everyone to live well. And so we believe that everyone should have a fair and just opportunity to be as healthy as possible. I think for us, the drivers for that work are three. One is leadership, two, accountability, three is continuous learning and transformation of care. So the first one, which is really the point of your question, is around engaging leadership. And we're fortunate at Advocate Aurora that we have a board that's very engaged around our DE&I work. In fact, we have a subcommittee of the board, just like we have a finance committee, a compensation committee, a safety health outcomes committee. We have a DE&I subcommittee of the board that oversees the work, engages and challenges all of us. And we just think that's wonderful leadership. So it starts at the top of our board. Next is our C-suite, our CEO, Jim Skogsberg, and my C-suite partners. Everyone's all in. We know that this cannot be assigned to one leader or one department. Everybody is engaged in this work across the C-suite. And then, as mentioned earlier, we have a Health Equity Council, and it's the Chief External Affairs Officer, Christy Garcia Thomas, and myself, who are privileged to co-lead that council. That council, again, is cross-functional leaders. It is not one department. It is data and analytics, DE&I, government affairs, nursing, population health, medical group, community affairs, ethics, strategy. Everybody's at the table at our council. Second, accountability. We have a DE&I dashboard. There are currently, for this year, 5 measures on that. 2 are around workforce, person of color management, person of color physician representation. The third is community based. In other words, we track business diversity spend. And then the last 2 are clinical for our consumers. And those are closing the gap for uncontrolled hypertension in our Black and Hispanic patients compared to our Caucasian patients. And then the second is safe reduction of C-section rates in Black patients compared to our white patients. So closing those gaps. So that's how we are holding ourselves accountable on these system metrics. We hold our leaders accountable. That also gives us visibility across the entire organization. And lastly, the third bucket, continuous learning and transformation. Our Health Equity Council oversees that and monitors that. But again, that is collaboration across many groups, our population health teams, care management, DE&I, research, nursing, our medical groups all come together to monitor that.
Thank you. Thanks so much. So many common themes in terms of accountability and measurement and data, and making all of your efforts more transparent, which there's so much we'd love to hear more about. So at this point, I'm going to ask you all a series of questions for a moderated conversation. But I encourage our audience to be thinking about questions that you have for our panelists, because I will be turning to you all in a few minutes for your questions. So one question I have for all of you is, as we think about the audience on this webinar, what piece of advice do you have for other organizations in truly engaging their CEOs and boards in this important equity work?
Well, I'll go ahead. I think that having that visibility of the pledges that we've made at the board level and the C-suite level, if you don't put it into action, it's really just empty words. So I think for an organization that is metric driven, goal oriented, to ignore a pledge that you've made or any other important work, and it's part of our strategic plan also. So just as safety, health outcomes are foundational to our strategy. Equity is foundational to our strategy. So it's front and center for all to see.
I'll add on to that, Gary. I think couldn't agree with you more. We have to engage our boards in the work and encourage their accountability of holding us accountable essentially for the work we need to deliver in this. And I think that it's as important that we're supporting our boards and becoming diverse themselves and adopting really the equity mindset into how we govern. And so I think it is really important to, as a C-suite, be talking about the diversity of our boards and how we're encouraging diversity, certainly race and ethnicity, but also gender, sexual orientation, income level, and how what systems and processes are we using at the board level to enable participation by a diverse set of trustees in our governance. At Intermountain, we have several hundred trustees involved in governance. Not all have fiduciary responsibility, but we have very diffuse responsibility for overseeing quality of care and service to the community at every hospital, and then boards to oversee our health plan and other components of the work. And this kind of broad engagement in governance creates lots of opportunities for engaging diverse perspectives and can help us to meet our mission more effectively. So creating that accountability for our trustees is equally as important.
I'll try to add on without repeating my fellow panelists too much. I love the theme again of accountability. And I would challenge us to do some introspection, considering ourselves all to be actors in the healthcare ecosystem. And so asking ourselves questions: why are you in this space? Why are you on the board? What responsibility do you hold? What power or decision-making authority or autonomy do you have? Are your current policies perpetuating harm? And then I would make the suggestions, as Mikelle said, look around the boardroom. Who's missing? How do you fix that problem? Look at your clinical outcomes. Do they match your branding, your messaging? And then third, I would say try. Health equity is a journey. There is no perfect model. There's no precedent. We are facing really 300 plus years of systemic inequality, and it's not an overnight fix, but you have to try. And so I think so many times we hear of systems and actors within systems spinning wheels, trying to figure out what is the best solution forward. Try.
I'd add on to that, Dawn. The problems seem infinite and you can get overwhelmed. And so for us, it was, starting somewhere, knowing that we weren't going to accomplish everything, and also that we were going to make mistakes. And we also, as leaders, tried to give each other grace, because we knew this was a learning system and that we need to course correct, which we did along the way. But to not start somewhere is a mistake. And so I think one piece of advice is to try to just see where some gaps are and start somewhere, learn from that, and then expand. We're hoping to grow our metrics list by leaps and bounds over the next few years, hoping to make a difference.
Yeah, I appreciate that from all of you. And a follow-up question I have, and given what you said, is how do you give advice, or how do you recommend supporting the board, and CEO, given that it is a journey, given all that you said about you just have to try. I'm just curious if you have thoughts on, ways in all of your roles as you think about supporting the board and CEO in that journey to keep trying to keep going.
Well, I think having the visibility at the board helps a lot, and having, the subcommittee for us helps a lot. Our CEO also communicates on videos every 2 weeks or so. It was during the pandemic, at the height of the pandemic, weekly, but talking about our DE&I journey on our on our report card and giving visibility across all of our team members. It really, by that work itself, keeps everyone engaged, keeps the C-suite together, keeps our CEO at the forefront of that great work, and then reporting back into the board and having the advice of the board.
I'll echo everything that Gary said again. And I also think it's celebrating the small wins. It's really celebrating, understanding the win, and reporting that up. And again, we already mentioned it's a complex problem. We can't solve this overnight. We're going to have many obstacles and setbacks, but keeping the board engaged by showing that you are making a difference, that you are able to improve outcomes.
I'll add, I think it's really important for us as leaders to be transparent with our own teams and with our boards about the inequities we're discovering. And I think that's something leaders always struggle with. We don't want to show our boss, our board, the things that we're doing wrong. And yet that's the only way we're going to make improvement. And so, and have the encouragement and support of our boards to do this work. So we've got to begin showing the disparities in transparent ways in our, whether it's in our internal practices of employment or the way we conduct our business, administrative functions, the clinical care delivery, or the issues that we're facing in trying to change the systems. I think it's helpful for us to educate our board regarding those disparities.
Yeah, I appreciate that from all of you, and some of the principles that you're calling out, it seems that there's a broad applicability even beyond engaging CEO and the board, but engaging the whole organization. And as a follow-up to that, I'm curious how you and our other organizational leaders and your CEO and board are thinking about engaging the communities that you serve as part of the efforts to transform healthcare delivery, as part of your efforts to transform healthcare delivery.
I'll jump in. So, I mentioned earlier that we really see our commitment to health equity as a partnership with community-based organizations. This is amplifying the work that is already being done on the ground. It's providing financial assistance. We know that many of these groups are operating on a shoestring budget, under-resourced, and serving people who are under-resourced. And so sometimes that also looks like providing financial assistance. And then there's also technical assistance. Earlier this year, Maven partnered with March for Moms with a new program called Impact for Families, and it's to support community-based organizations focused on maternal health outcomes. It's a 12-month program, and it's designed to support 2 organizations at a time. And actually this week, 2 days from now, Chocolate Milk Mommies and Black Mamas ATX are joining us in our New York office to meet with our executive leadership and to share in co-learning opportunities and experiences, including work groups to build out their advocacy, fundraising, and social media strategies. And so what does this look like? It looks like arranging the lunches and arranging the dinners with philanthropy. It means sharing our contacts and our networks. It means sitting and providing templates for agendas or strategies. It's pulling our senior vice president, our executive leadership into a small conference room, and you sit there for 90 minutes. When you walk out, you will have a strategic plan in hand. There are a number of other partnerships that we have as well. Again, because we are an employee add-on, we are able to offer our services to community-based organizations in pilot program form, where people are able to receive the same benefits as those who access Maven through their employer. It's an ongoing process. And again, having the commitment of the board to say, yes, you can write this check, you can bring people in, you can spend days in office using all of the skill and all of the talent that we were recruited for to come to Maven. We can use that to build out programs that are on the ground and again, under-resourced.
Tara, I'll take a little different angle. I think, health systems are really have their roots embedded in place. We are a part of the fabric of a community, usually, as Gary mentioned, largest employer in his service area. Intermountain's in the same situation. And so we have to continuously work at building relationships with our community to be a trusted partner. And that means, relationships of trust are built very slowly, and they can erode really quickly. So we have to, I think we have to be responsible to ensure that we are building relationships, particularly with marginalized and vulnerable communities that might not be accessing healthcare in equitable ways, and create outreach and support. Much as Dawn described, we need to be a part of supporting those different community-based organizations all the time. And then as we do this hard work of understanding the disparities that exist in the healthcare that we're delivering, we need to work with those communities to hear what the perspective is, their lived experience in experiencing that inequity, and what they think can be done to solve it. And so, what this looks like for us, I think having a relationship with the Black Chamber of Commerce, for example, and establishing that relationship of how can we help you with the things that we find in common. We want to help support business growth in the Black community. We want to address the disparities in hypertension. These are the things that we care about at Intermountain, but we've got to listen to what the priorities are of that organization and try to line those up. And when we discover the disparity, like hypertension disparities, we have the relationship and the opportunity to delve deeper and listen. And so I think we have to be building from the ground up a relationship of trust over time, but then working really together in accomplishing a shared outcome, something we both care about in solving together.
Mikelle had a quote for me with building trust. We could not do this work without our community partnerships. During the pandemic, COVID education, COVID vaccines, COVID testing, if we didn't build trust in certain communities with our church partners and others, we would not have been able to make the difference that we did. I think another way that we use those partnerships are after we do social determinants of health screening, connecting with certain agencies and community partners to help close some of those gaps and to connect patients to resources so that we can actually improve their health. Perhaps they have like transportation or housing insecurity or something like that. If we don't address that, we're not going to get them to optimal health, and yet we can't do all of that ourselves. So those partnerships are essential.
Essential. That's exactly right. Thank you all so much. And now we're going to turn to the audience questions. We have several questions that have come in already, which is great. And I want to remind everybody, you can put additional questions in the chat. We welcome them. So the first question for the panelists is, can any of the panelists point to specific initiatives they are undertaking to address health inequities at the intersection of disability and race? In data collection, are any of the panelists integrating disability questions as required by HHS?
I'd be happy to speak to two examples. I'm not sure that they speak to everything that was identified in that question, but the issue of identifying different ability levels is important to our organization. We're finding, I'll share two examples. We're really focused on employment, ensuring that we are employing all ability individuals as much as possible, and then thinking about our role as we all are an insurance company as well, our role in helping people live the healthiest lives possible who are insured with us, regardless of ability. And so one disparity that we've found for our members is in the way that we communicate with people who are hearing impaired, and really doing a better, it's become really apparent that we haven't done a very good job of understanding hearing status, connecting then all of our communication strategies for our members so that they follow them through the course of their lives, not just in engaging with the health plan, but being ready and anticipating their need for a video visit, for an in-person visit, and proactively reaching to members to ensure that we're communicating effectively. A second example, we know that people with physical disabilities or mental impairments have less access to employment opportunities at Intermountain. We can see that. And so we have created specific pathways through community-based organizations who are helping provide that support around individuals with other ability levels to get into the workforce. And we're partnering with them to create successful pathways into jobs that have the support of that wraparound community-based partner, as well as a leader who's trained in how to support an individual and create those pipelines. One of the, we've worked with people that are in disability coverage for entry-level jobs in our laundry and other areas where we've had difficult to employ pathways for those individuals. And we're now looking at individuals experiencing autism and what are those routes for employment. So I think this is really important. And yes, there is some intersectionality with race, but I don't have any examples explicitly at my fingertips around how that's been applied in our environment. So happy to defer to others.
I'll jump in really quickly and say again that our personalized care plans is where we make accommodation for people based on their own lived experiences or their needs. And so you are going to meet with what we would call a care advocate who acts as a navigator, and they are going to tailor the birth plan or your family planning journey, your fertility needs, whatever it is that you're using Maven for. Again, it's tailored to meet people and members where they are. And I will say that one thing right now that is on the list of priorities, again, because we are a digital platform, most people access us through an app. It is translating the app for visually impaired members and figuring out what's the best way to just make sure that as many people as possible, regardless of ability or disability, are able to access our platform.
Thank you for those examples. I'm going to move on to the next question, which is for Dawn. Dawn mentioned vetting suppliers for health equity goals. Can she share more about the list of questions posed to suppliers?
So that's actually on my business growth side of the organization. So if we can do a follow-up, I can do that.
Okay, great.
Thank you.
Thank you. The next question is, how can organizations address labor and workforce development practices in diversity, as well as policies related to board members, executive leadership, and pay?
That's a really big question. I'm happy to share a few examples. As health systems evaluate the requirements around job description requirements, minimum qualifications, et cetera, we're learning that we need to take a very minimal approach. Wherever possible, challenge ourselves. Is a master's degree required? Is a college degree required? Is even a high school degree required? A lot of these requirements have perpetually rolled forward without thought to actually what experience can offset a degree requirement. Sometimes that experience is far more valuable than the degree. We're also working to understand our background check processes, our reference checks, our criminal background questions. Asking those types of questions at later points in the process rather than upfront can create more accessibility to a large portion of our potential workforce that won't apply to us because they perceive that they have something in their past that would preclude them from being able to work with us. When in reality, many of the infractions that people have on their criminal records are not impediments for employment in lots of jobs with health systems. And so really getting critical about where are we putting these unintentional barriers up for people that we can move to different parts of our process or approach differently is really important. And I think it takes working with partner organizations who are advocating for previously incarcerated, previously substance use populations, veterans populations who are approaching our application process from a different lens, and inviting their feedback on our processes is essential. And there's no time. I saw someone else ask a question about how our labor shortage is impacting this. This is the right time in a labor shortage for us to be asking these questions, because it helps us in the business imperative of continuing to care for the patients and members we're looking to serve.
Thank you.
So everything that Mikelle said, of course, about trying to get people in the door, I'll talk a little bit about what happens once people are here. We know that you have to build an inclusive environment. Your company culture is going to make the difference between whether people stay or they don't, whether people are able to thrive in the workplace or not. So there are a few things that we find that are helpful towards this. One is transparency, salary transparency. So people know how the company values them. Two, we have job architecture on day one. You learn and you understand what your promotion schedule looks like, when you can anticipate raise or promotion, and twice a year we do performance review and performance check that's not tied to compensation. And then third, I mentioned a little bit earlier, we have a number of affinity groups. We have Black at Maven, we have Queer at Maven, we have underrepresented gender identity. It's a tech company, so we have a lot of people who identify as male as engineers, and then a handful of people who don't. So making sure that you can be your authentic self at work goes a long way towards building out our equity and really maintaining our foundation for equity.
Thanks so much. Next question is, how do each of your organizations tackle inequities that tend to be outside of the healthcare realm, that sometimes leaders deem out of our control, i.e. insurance payer issues?
That's a big one.
Yeah, it is. All of these are really.
Well, I would say that first of all, the plans in our market are starting to. We actually have some contracts with plans that hold us accountable for health equity measures. So I think some of that is changing, and so is CMS and the federal government. It has a big push on now, I think most of you know, to include equity in their future programs. So I think that's moving in the right direction.
I can add, one of the inequities that we experience in our community that impacts health in very real ways is the inequity in insurance status of our communities. And when we look at one of our markets, Utah, where we're based, the number of children who are eligible for coverage but are not enrolled, we have one of the poorest rates in the country, actually. And when we understand the detail in what's driving that, it appears that mixed immigration status of families is a major barrier to families feeling comfortable with enrolling their children in CHIP or Medicaid. And so while it's, this is something we built a coalition around trying to address enrollment. It has participation by state, by health plans and health systems, but more importantly, a lot of community-based organizations and enrollment assisters and others who are thinking through approaches on how to address that problem. So it's an inequity that is definitely outside of our control. And yet it's something only by working together can we solve. And if we do, it has a lot of downstream impacts on our ability to improve health and resolve the other health disparities that we see affect the same community. And so that's an example of ways that we can work together through coalition building and collaboration.
Mikelle, I just want to second that. I think we've struggled. Are we holding ourselves accountable for just our patients or the communities that we serve? It's easier for us to measure our metrics and hold ourselves accountable to folks who are in our electronic health record, and yet we are hoping that through those partnerships and through the work that we're doing, we have a halo effect on the communities for those that are outside of our direct care, and that we're improving those zip codes and communities in good ways through the broad work.
Thank you. And did you want to jump in?
I'll just talk really quickly. We actually just launched our first pilot program with Blue Cross Blue Shield of Arkansas to provide our benefit to Medicaid recipients. And so moving into a different population with different population needs, it is a all hands on deck endeavor to make sure that we are able to, one, deliver our service, but also to not just drop the bag when people come to us and say that they have insecure housing or food insecurity. And so through our partnership with Blue Cross Blue Shield, we're working to address those non-clinical factors.
Yeah, thank you so much. All right, so we are turning to our last question from the audience. There's been so many, and I just want to note that if your question was not answered, we will get back to you in the post-webinar communications. So for the last question from the audience, has the Maven Clinic, so this is for you, Dawn, at first, has the Maven Clinic considered adopting inclusive language to better support the queer community, to better support the queer community? Transgender and gender nonconforming patients might feel stigmatized by language around services being for women. And then there's a follow-up for after.
Sure. I think it's the $1 million question. Prior to, I guess 2 roles ago, I worked at the National Partnership for Women and Families, collaborating with many organizations and companies, including Maven, who, let's be honest, 5-10 years ago, 100 years ago, some of these organizations are old. We were in a different place than we were today. And so for Maven, this is a top line priority. A large number of our members access our services because they are in same-sex relationships or because they are non-gender conforming. And so when we talk about our content, our delivery, it is gender inclusive, the language. And I mean, this is going back through every piece of external facing content and then building internally our own muscle to be able to address the needs of all people. We also have a number of providers that we are able to connect people with who not just checking a box, but actually have real experience working with people in the queer community so that members do feel included and comfortable at Maven. If we change our name or change our tagline, that's a question for my CEO. I can continue to push her on it, but I know it's one that many, many companies and organizations are really struggling with. So I thank you for flagging it.
Yeah, and I'll just give Mikelle and Gary a brief opportunity if you want to speak to how your organizations are addressing equity when it comes to transgender and gender nonconforming patients.
Well, there's a lot of components to this. As Dawn described, it's every department's responsibility to think through that lens and update language around policies and procedures, publicly facing documents to reflect what we understand to be true about our community's needs today. And then we have an LGBTQ health part of our organization being led by a physician and an administrative leader, just as we do lots of other aspects of health that are important for us to focus on. And this team is really being intentional about outreach to community-based organizations that work in advocacy or support to our community and ensure they understand the access that's available to them to healthcare, the disparities that exist in health outcomes, and that they know and can trust there's a friendly place to come for care. That includes then extending into our clinically integrated network of demonstrating through advocates and others, letting providers self-declare, I have a particular area of expertise or interest in serving these needs in our community, and that can create broad geographic and varied reach across our communities. And these are all works in progress, but we have to keep doing more of this.
Yeah, thank you so much. So we are at time. I really, truly want to thank you all, our speakers, for such an important discussion, and our audience. We had such great questions, which we'll be following up on. I mean, I heard so many important themes around accountability, transparency, engagement, inclusivity, and real partnership and relationship building as part of this work to engage CEOs and the board, and really to transform healthcare organizations to advance equity. I hope you'll all spend time with the Raising the Bar resources, which highlight organizations already working, just like these on our discussion today, to raise the bar and provide insights to guide action and call for all stakeholders to join in this effort. So thanks again to our panelists and the many partners who created the Raising the Bar framework. And on behalf of the Robert Wood Johnson Foundation, we are looking forward to working with all healthcare organizations to advance equity and well-being for everyone. So thank you so much, and I hope you have a great rest of the day.